Hello and good evening. Ms. Christina Sunarine. I will be serving as the introducer for our debate. Hannah will be serving as the supporter. Amanda will be serving as the opposing side, and Crystal will provide illustrations. Heather will serve as the fielder and the debate closer. We have chosen to follow an informal style of debate. Children with autism spectrum disorder are increasing in population size. According to Byrne and Wolfberg, it is an increasing prevalence of ASD and is set to be 1 in every 50 children, as opposed to the national prevalence of 1 in every 88. Due to an increase in the number of children with ASD environment, it is important to consider the need for professionals to be equipped with well-rounded knowledge to work with these children under all circumstances. With this in mind, we want to propose and discuss the concept of individuals with autism and other disabilities who engage in severe aggressive behavior and injurious behavior, and how they can pose a significant threat to individually themselves, peers, staff, teachers, and parents who may work with them. Furthermore, we'll discuss the use of least restrictive procedures and consider when the restraints and seclusion may be necessary to prevent self-harm and harm to others. We will address items such as, is the use of restraints and seclusion ethical? What role should analysts play in interventions involving restraint and seclusion? And lastly, does the literature and the ethical code indicate that it is appropriate? Before we jump into the debate, I'd like to draw your attention to a few ethical codes. First, I would like you to consider the ethical code in section 1.0, Boundaries of Competence, which explains that behavior analysts should provide services within their boundary of competence. They should further pursue training or further education when it's considered appropriate. Hannah will further touch on this topic. Second, I would like to draw your attention to the section 4.01, Conceptual Consistency, that provides the expectation that behavior analysts should provide behavior change programs that remain consistent with analytic principles. Next is one of the more important topics that we'll touch on, and it's in section 4.08, Considerations regarding punishment and procedures, which outlines the importance of using reinforcement techniques before falling dependent on punishment. Amanda will further touch on this topic. Lastly, section 4.09, least restrictive procedures, states the importance of using least restrictive procedures, which we will hear more about shortly. I will now hand the floor over to Hannah, who will begin discussing the pros of using restraint and seclusion.
Hi everyone, again my name is Hannah and I will be discussing with you the arguments in favor of physical holds and restraints. There is no doubt that the use of restraint and seclusion is a controversial topic when talking about autism and people with special needs. Like many things, there is some gray matter. There are pros and cons to many things in this life. But when discussing this topic, I want to begin with talking about the pros. One of the bigger arguments that people use to support the notion of restraints and seclusion is to have controlled safety for the client, teacher, and therapist. Children and adults whose problem behaviors include self-injurious behaviors and physical aggression have the potential to cause harm to themselves and other people depending on their age and size and the intensity of their behaviors. For example, according to Oregon Live News, in May 2012, an autistic boy in Oregon attacked his school bus driver on the way to school, which led her to a hospital visit. While there were many other safety concerns in this scenario due to a vehicle being in motion, had the bus driver been able to restrain the child, the problem may have been solved. Another example takes place in Naperville, Illinois, in a special education classroom where a student went into a tantrum and injured a teacher. The reports say that the student threw chairs and books and at one point raised a chair over his head to strike the teacher with it. And the teacher in this situation was pushed and she fell against a board, injuring her head and her neck. In this particular situation, had the tantrum been resolved early on by using a restraint, the teacher may have come out unharmed. One of the other arguments in favor of restraint and seclusion involved training of the holds. ABA is still a very new concept to many people, which is important to note for this topic specifically. Throughout generations and even within the past few years, training for proper holds and restraints have developed and improved. There are strict movements and procedures that make restraints very safe for clients. In a forum written by Dr. John R. Lyon, a report was done on restraints in psychiatric hospital patients. While these people may not necessarily have autism, Lyon mentions that the use of proper training significantly decreased hospital staff assault rate. Lastly, in a post written by Lauren Rabin, Rabin further explains why restraints are in fact ethical. In the article, she mentions that she met with the vice president of the Professional Crisis Management Association, Meryl Winston. The two discussed the controversy of holds, and she brought up the idea that parents of young children use restraints in many different ways. They hold a child's hand in a parking lot or block their hand from touching something hot. And the same goes with seclusion. You think about timeouts, and they're basically a form of seclusion. Merrill states in the interview that there's a commonly held belief that teachers, therapists, etc., are using restraint as a form of punishment. Merrill is so right in saying this, but ideally, restraint and seclusion should only be used for safety purposes. With this being said, Merrill didn't shy away from what he believes to be the truth. He said, unfortunately, there are bad people in the world who do not use restraint properly. Restraints have in the past been used inappropriately, used with malice in a way that hurts the child, and it will be again. There are bad people, but most of them are not. This statement, while heartbreaking, is true, and it is the same for many other areas of schools and clinics. There were and there will be ways for children to get hurt using restraints and seclusion. However, the stories about safety of staff, parents, guardians, and other children because of restraints is never talked about. Like Merrill states, there are bad people, teachers, there's bad leadership, but that can take away from all of the good and safety that can come from using this sort of an intervention. I wanted to finish by talking about the ethical code, which Christina mentioned at the beginning. First and foremost, it is important to mention that these types of interventions should only be used as a last resort. Other interventions should be implemented first and should be paired with reinforcement. Code 4.08 is titled Considerations Regarding Punishment Procedures. It states, behavior analysts ensure that aversive procedures are accompanied by an increased level of training, supervision, and oversight. Behavior analysts must evaluate the effectiveness of aversive procedures in a timely manner and modify the behavior change program if it is ineffective. Behavior analysts always include a plan to discontinue the use of aversive procedures when no longer needed. I feel that this code still gives the freedom of using restraint and seclusion, but it is only to be used if it is absolutely essential. This wraps up my thoughts on restraint and seclusion, and I'll now pass it over to Amanda to discuss the negatives of using restraints and holds.
Thank you, Hannah. Hey guys, my name is Amanda Kirk. I'm happy to talk with you today about my thoughts on physical restraints and seclusion and why we should not use them as excessively as we do in our facilities. So while the utilization of physical restraints and seclusion may, upon first glance, when you're first looking at it, appear to be the most viable option when facing physically aggressive persons with cognitive disabilities such as autism, it is in fact one of the most hazardous. So I want you to stop and go on a journey with me and think really quick about physical restraints and think about driving a car, okay? So physical restraints are often like cars. If a person drives down a road in a car and with integrity, they maintain all the road signs and rules, like they don't speed, they're not throwing trash out the window, they're really following the rules of the road, okay? They're not texting. Watch out for that. So they're doing a really good job, right? Then a car can be a wonderful tool to quickly get people from one location to another location. However, if attempting to drive a vehicle without maintaining these ethical rules of the road, lives are put at risk and vehicular manslaughter may occur. Just think about drunk drivers. That's the prime example to me of how loss of life can quickly happen because people are being unethical on the road while they're driving. Persons who are well skilled and trained in the use of physical intervention procedures as designated by the facility or the company they are employed by, and maintain at a minimum a yearly retraining to ensure skills have not been lost, can be a great asset to ensure the clients in crisis remain safe. Safety is our first priority. As a supervisor at my job with my kids who are very vulnerable, who have been through so many different things, it's highly important to make sure that my team keeps my kids safe. But however, finding those persons who are willing to adhere to Ethical Code 1.04, specifically looking at Integrity 1.04c, that states behavior analysts should not engage in any contingency that may promote fraudulent, illegal, or unethical conduct is a very difficult task. The situation becomes even more dangerous when seclusion practices are added into the policies of a facility or company. Look at Sunland Miami scandal in 1972, which was the reason we're even here right now having this class, having this debate, is because a group of people who intended for something good initially to occur, a facility to help people who had cognitive disabilities or who had autism, in turn changed it into a facility that unfortunately caused a lot of damage to a lot of people. And we know about that. We read about that this semester. And so it's highly important that we pause and consider the hands who are implementing these restraints and the hands that are putting these children and these adults into seclusion rooms that may not have the best intentions in the end, especially about their supervisors present. So we're going to dive into an article written by Heather Vogel from ProPublica.org that was published on ctwatchdog.com, and it discussed the violent and legal ways school children are being held down against and even isolated against their will. Think about being unable to speak, okay? Unable to have a voice. Pretend that you had autism, okay? And pretend that part of who you were as a person with autism meant that you were unable to share your thoughts, okay? Say you felt them here, but you couldn't express them here, okay? Think about how awful it would be if you were having, say, a really bad headache or a migraine and you felt terrible, or even a toothache. Those are the worst. And while having this toothache and you're in pain and you're throwing your hands because it hurts so bad and you just need help. And in that moment, those around you who are supposed to listen and be your voice and take care of you, in turn, jerk you, pull you, throw you into a room and don't keep you safe. And that's what happened to Carson Luke. Carson Luke's a 10-year-old without order. Carson had been crushed in a door while staff were attempting to lock him into a seclusion room at Southeastern Cooperative Education Program's Deep Creek facility in Chesapeake, Virginia. I think we have a picture of his injuries to share with you. We know that his family was highly upset, and you can see his hands and the marks, but we know more than just the physical injuries, the emotional trauma that it brought onto Carson and to his family would probably make it very difficult for them to even be able to trust further educational staff, and especially to let them alone again with the staff at that facility. And so it further shared that children often receive head injuries, bloody noses, and even death. In one particular seclusion event in Georgia, there was a 13-year-old boy who hung himself with a rope that was used to tie his pants up because they were falling down, and he didn't have a belt. And he actually was left so alone and so isolated in the seclusion room that he hung himself with that rope. In 2009, the Government Accountability Office found that at least 20 children have reportedly died from being restrained or isolated over the course of 2 decades. Loss of human life is unacceptable. I'm going to say that one more time. The loss of human life is unacceptable. It's damaging to facilities. Injuries are one thing, and they're bad. They're bad enough. But when you're talking about actually the loss of somebody passing that's in your care, that's entrusted to you, that's somebody's baby. Okay, that's somebody's son, that's somebody's daughter, that's somebody's sister, that's somebody's brother. Okay, and their chest was maybe being held too tightly. they weren't being monitored closely in seclusion. The loss of human life is unacceptable. That will destroy programs, that will destroy our reputation, and that will destroy our field. We can't afford for that to happen. Our first priority and a main core ethical principle as behavior analysts is to do no harm to those that we serve. In a study completed by Jennifer Connolly, published in the Research and Practice for Persons with Severe Disabilities in September 2017, seclusion of students with disabilities was researched over a course of 12 years. In this study, she shared findings from 26 due process hearings that took place nationwide. Now, if you work in education, due process hearings, you're familiar with those because you know IDEA law and you know FAPE, and you're familiar with understanding that a parent has the right to a due process hearing if they are unhappy with services. But back up, rewind, if you're not familiar with due process hearings, perhaps you're not familiar with the education process because maybe you work in a clinic, then there's no harm in that. It's just different setting. Let me express to you a minute what a due process hearing is so you'll understand this article even better. So a due process hearing is like a courtroom trial for you in the school, right? So during the hearing, you can call witnesses, you can get evidence, and you can make legal arguments. A trained, impartial hearing officer acts as a judge and makes a judicial decision about the case. So that is a due process hearing. So for the purpose of her study, seclusion was defined as the involuntary confinement of a student alone in a room from which the student is physically prevented from leaving. Findings from her analysis include the following: that students of all ages and both genders with significant cognitive and behavioral disorders were subject to seclusion. The rationale for the use of seclusion did not always involve a safety concern, and students experienced an escalation in behavior upon being placed in seclusion, along with high frequencies and long duration of the seclusion event. Many students in the study had a variety of physical and mental health conditions and cognitive disabilities. But let's put all this on pause for just a moment. Remove everything, clear your head, take a breath, and remove everything I just shared about the improper use of physical restraint and seclusion and the physical injury that can ensue. And let's look deeper at the intervention itself, because we're behavior analysts and training. We want to do this. So we're thinking about behavior plans. And part of behavior plans may include the use of punishment procedures. So let's look at the intervention itself and the trauma that can occur as a result of the behavior intervention. So Ethical Code 4.09, least restrictive procedures, states that behavior analysts review and appraise the restrictiveness of procedures and always recommend the least restrictive procedures likely to be effective. Using this ethical code would help to ensure that behavior change programs cause the least amount of trauma to clients, especially for those with cognitive disabilities such as autism. In the Journal of Autism and Developmental Disorders, Kearns, Neuschafer, and Berkowitz published a 2015 review of the traumatic childhood events in autism spectrum disorder. They define traumatic childhood events as any childhood event that are associated with a wide range of negative physical, psychological, and adaptive outcomes over the life course and are one of the few identifiable causes of psychiatric illness in the future. They identified that children with autism spectrum disorder may be at increased risk for both encountering traumatic events and developing traumatic diagnoses due to those events. While there has been limited research diving deeper into this topic, there is definitely a link between trauma and increased physical aggression. I see it all the time. You see it all the time. We will see it all the time. Many agencies, including Canopy Children's Solutions in Jackson, Mississippi, where I work, encourage the use of trauma-informed care approaches to ensure all staff consistently, actively think about the effects of their actions on the vulnerable clients served, even requiring trauma-specific trainings such as risk and connections to be implemented and practiced with all hired staff. In a 2008 article written by Howard Bath entitled The 3 Pillars of Trauma-Informed Care, he describes 3 focal points of interest for practitioners to ensure positive outcomes for interactions with clients. Safety, connections, and managing emotions are 3 core ideas behind ensuring trauma-informed care. Now, while these are pivotal ideals and different from applied behavior analysis, not necessarily what we're trained in, but maybe trained in for a company we work for, they do correlate with our ethical principles. Making sure that we do no harm, making sure people have autonomy. So managing emotions is one of the most challenging issues for staff engaging in physical holds and can lead to unethical behavior. And I wanted us to think about that for a minute, making sure that we watch our staff, because oftentimes what will happen is with good intention, when they want to help a child, they'll go into the physical hold procedure process and they won't realize that in the middle of it, they're feeling completely out of sorts and their adrenaline is pumping, the staff's adrenaline is pumping, because 30 minutes, 40 minutes in a timeout room situation can be very stressful and provide vicarious trauma for the staff working with them. So I think that's really important that we remember that we have to evaluate our emotions as practitioners. We have to stop and think, okay, you know, like as Hannah said, that people want to use physical holds. If that's the case, then we really need to stop and consider the trauma that we could cause, because once something happens in a physical hold scenario or in a seclusion scenario to one of their little guys with autism or cognitive disabilities, can't take that back. What's happened has happened. What's out there is out there. And now it's time for a debriefing. Now it's time for repair and restoration of that relationship. Because, man, the thing is oftentimes, as I said previously, these hold procedures are used, seclusion practices are used without due cause. And that's not fair to the clients that we serve. So ultimately, as behavior analysts, it is our responsibility to ensure that we minimize the risk of harm to the fullest extent possible, while ensuring that if we observe anyone, including ourselves, engaging in harmful and unethical practices, we utilize Ethical Code 7.02, ethical violations by others and risk of harm, which states, if behavior analysts believe there may be a legal or ethical violation, they first determine whether there is a potential for harm, a possible legal violation, or a mandatory reporting condition, or an agency, organization, or regulatory requirement addressing the violation. If a client's legal rights are being violated, or if there is the potential for harm, behavior analysts must take the necessary action to protect the client, including but not limiting to contacting relevant authorities, following organizational policies, and consulting with appropriate professionals, and documenting their efforts to address the matter. If an informal resolution appears appropriate and would not violate any confidentiality rights, behavior analysts attempt to resolve the issue by bringing it to the attention of that individual and documenting their efforts to address the matter. If the matter is not resolved, behavior analysts report the matter to the appropriate authority, like your employer, supervisor, or regulatory authority. If the matter meets the requiring reporting methods of the BACB, behavior analysts submit a formal complaint to the BACB. Guys, and the truth is too, if we don't do this, our license is at risk. Our profession, our career is at risk. And we are the only voice that our children have. Using physical restraints and seclusion practices ultimately can be damaging because you don't know whose hands you're putting them in. And those are my thoughts on why we should avoid these practices. And now I would like to share some more information through Crystal, who's going to share some visuals with you today.
Thank you, Amanda. Hi, my name is Crystal Carter, and I'll be explaining some illustrations showing what a seclusion room, physical and mechanical restraints look like. Also, I'll briefly explain some statistics of restraint and seclusion. In this picture shows a boy that is sitting in a seclusion room and isolated from others. Research has shown that the last several years, the national news reported several usages of seclusion rooms in schools across the United States. There have been many investigated cases involving the abuse and deaths of using seclusion and restraints in schools and treatment centers. Seclusion can be classified as the term timeout, which is defined as reducing an inappropriate behavior by denying a student access for a specific time. Timeout is divided into 4 levels ranging from least to most restrictive. It includes inclusion timeout, exclusion timeout, seclusion timeout, and restraint timeout. Seclusion rooms became common in special education settings in the 1970s and 1980s and was used on students with emotional and behavior disorders. Reports have shown that some teachers use seclusion for non-emergency situations, such as leaving a non-assigned area, non-compliant, interrupting class, disrespect, harassment, and property destruction. In 2011 and 2012 school year, it was reported from the Office for Civil Rights that 37,000 students were put in seclusion and 58% of the students had disabilities. My next picture, and this picture shows a teacher physically restraining a student and a diagram showing different types of physical restraints that can be used. A physical restraint is defined as one or more individuals restricting the freedom of moving, physical activity, and normal access of their body. Physical restraint is used to decrease the movement of the individual's arms, legs, body, and head. Physical restraint is used to control the movement of your child. These types of physical restraints are used in a variety of places such as hospitals, mental institutions, education agencies, juvenile centers, and mostly in schools. The use of restraint, such as displayed in the illustration, is used to prevent injury to a child with disabilities and in time of crisis where it's an emergency. There are a variety of reasons that physical restraint is being used, including a student being non-compliant. A physical restraint can also be used to take the student to seclusion room, as described in the previous illustration. As more students with emotional and behavioral disorders are enrolled in a general education classroom than a special education class, then the higher the chances of using the physical restraint on them. Studies show that physical restraint can cause psychological harm to children that were previously abused. And my next picture shows what a mechanical restraint looks like, using a chair and belt to strap individuals down. A mechanical restraint can be any type of device or objects consisting of tape, ropes, weights, and weighted blankets. These objects help to limit the body movement from others and control the behavior. In school settings, mechanical devices are used with people that have physical disabilities such as cerebral palsy. These individuals use the chairs or standing tables with restraints, which permits them from engaging in any educational activity where their muscles or bones would not allow them to participate. Reports stated a 4-year-old that was strapped to a chair identical to the picture above was later diagnosed with post-traumatic stress disorder, which then led her to bedwetting and frequent cases of temper tantrums. Overall, there's little research showing whether or not mechanical restraints helps to control students' behavior in school settings. And my next picture shows a diagram of incidents in 2012 through 2013 school year involving students that were restrained and secluded. The highest level was autism, ranging from 40.4%, and the second lowest ranging from 1.8% for intellectual disabilities. Now I'm going to turn it over to Heather, who will be concluding the debate with some questions and answers.
Excuse me, I'm very sorry, I was muted.
So I was saying, thank you very much for the great discussion points. I think we had a lot of good pro and con sides. So what I'd like to do now are to discuss two scenarios that deal with this situation. So the first scenario is that you are working with a school that uses isolation and restraint procedures. And you are also working with a client who is very aggressive. She throws chairs, she hits, she kicks anyone who is nearby. As a behavior analyst, how do you work with the school and keep to the ethical code while keeping others safe?
Hey, I'm going to start sharing some things that I've had to do at my place too. I'm working with people who are severely violent. The thing you have to do is you have to make sure that your staff are monitored at all times, that they're not left alone with the child, because the situation is, and the reality is, it's oftentimes our kids who do have cognitive disabilities such as autism also have communication disabilities. So, and judgment impairment. And so sometimes when you may be engaging in a one-arm wraparound, say, okay, they may say, well, Mr. Berry was trying to choke me when Mr. Berry was trying to put me in a one-arm wraparound. And so having that third unbiased person there to be able to take data and to maintain the integrity of the treatment, and making sure that the procedure is being carried out with integrity is pivotal, and it saves a lot of jobs and a lot of lawsuits from occurring if you have that person there that can say, no, I was privy to this. Also make sure that your staff are acting and using the skill set that they were trained in by the facility to use as physical holds, because sometimes, you know, they're going to do it when their supervisor's there. They're going to do it when their chief compliance officer is there, or their principal's there, when their program supervisor's there. But the second that program supervisor walks away, what are they going to do? I would like to always think, and there's a good amount of trust that comes with my supervisees, and I do believe that, you know, I know that they're trained. I know that they care about my kids. I know that they're going to do their very best. But there's always that 1% when that person hits their wall and they don't know when to back out. They don't know when to say, I'm tired, I'm exhausted. I went through the loss of my family member last night, and I didn't tell you about it, and I'm here at work, and you don't know this about me. And so when this kid is telling me that they want me to die, and I am experiencing all of these different things, I'm not sharing that with you because I want to be a tough staff. And they hit their wall. And then as a result, sometimes it'll be too rough with a child, because, you know, the use of a physical restraint should not hurt anybody's limbs or joints. But again, that's not always the case. You look at Sunland Miami, who again was the pivotal turning point, unfortunately, for behavior modification, for our field, for applied behavior analysis, and saying, hey, we've got to have people watching, because in order to keep these kids safe, because they're going to engage in these aggressive behaviors, that's going to happen. We've got to make sure that people are being ethical, or we in trouble. And those are my thoughts on that question. Heather?
Thanks. Did anybody else have a thought they wanted to share?
I just wanted to add one quick thing that Amanda actually also touched on. I think it's really, really important that we touch on the fact that behavior analysts just have a major responsibility to make sure that their staff are trained and fully equipped to work with different children of different abilities, or different individuals with different abilities, and that includes those who engage in really aggressive or severe behavior. So I know that Amanda did touch on that, and that also is in the code of ethics. So, like, not only do we have a responsibility, it's part of what we agree to do when we agree to become a BCBA. And furthermore, I think it's really important to look into the fact that if those behaviors are occurring, we have to look at what triggers them and how can we decrease or change the environment to make it less susceptible for those kinds of behaviors to occur. And that might help both the staff and the child, or the individual that is performing them. And then lastly, I'd like to just add that we have to keep in mind that we need to always look at the least restrictive environment. In this event, if the child is, or the individual is throwing chairs and throwing things like that, maybe a form of restraint might be acceptable, but we also have to look that we aren't abusing that, that we don't want to result to something that is going to be a punishment. So that's what I have to say. I don't know if anybody else has anything to add.
I mean, I have something to add. Definitely what you and Amanda says is really good, because we do have to look at what caused the behavior, and maybe like implement like some coping skills, like find out maybe if there's like calming videos, music, or we can have an area where it's like padding area, where if they get aggressive, maybe they can, instead of hitting a wall or throwing chairs, they can hit the padding, which are not, you know, hitting others. Also, if they're sitting in a chair, I would definitely be in close proximity with the teacher, just in case he gets aggressive or she gets aggressive. It's not too close from other students. So that's definitely.
Right. Thank you. Those were some great discussion points. So here's another scenario. We have a student who has a past history of physical abuse. How would you go about this situation if she is, again, aggressive, hitting, kicking, throwing chairs? How does that work? How would you be able, would it be appropriate to use isolation and restraint with a child of this kind of background? And are these kind of things even being considered when we recommend a client is using that aversive or punishment procedure in their behavior plans?
I'll touch on this. I most certainly think that history of physical abuse should be taken into consideration for every single type of intervention that we use, or any type of abuse for that matter. And like Christina said in the past question scenario, environmental factors should be considered too. You know, how can we prevent this from happening? Let's look at the antecedent strategies. And also coming from the pro-restraint and seclusion side, you know, I think this can be a sticky situation. And I think that that's okay to say sometimes, and not always have like a 100% perfect solution. But I think, again, as I talked about in my portion of the presentation, you know, you have to look at the safety of the other people as well. You know, if one person is doing damage to multiple different people, you know, you have to take those people's safety into consideration as well, while also taking into consideration the fact that this girl had physical abuse. So that takes a lot of brainstorming and a lot of collaboration, but I think there can definitely be a good solution if that situation did occur.
Great, thank you. And so I have one more question. What considerations are being made in how isolation and restraint might affect a child emotionally? There is a literature review done in 2013 by Austin, Prieto, and Roosforth. And in this literature review, they found that the child's experience of single room isolation indicated that the children were feeling lonely, scared, they were bored, and that also the patient's parents were feeling guilty and they were worried and they were under increased pressure to visit their children. And it's also suggested that isolation may affect child development. So again, are we considering these things when we suggest that a child needs child and restraint procedures?
I mean, I sure hope so. I mean, that's the reason we have all of our ethical boards and our accrediting agencies like Joint Commission coming and observing and monitoring and ensuring that the practices that we're using, if we're using them, aren't going to be damaging to children. Man, you know, I think about so many times when a simple thing, like I think about, you know, the Judge Rothenberg Center that we talked about, that, you know, how easy would it have been for that child who was electrically shocked over 30 times? How easy would it have been to have implemented a positive program for him about removing his jacket when he came in to school versus, oh, we're just going to go to the most extreme situation, and we're going to mechanically restrain them. And then after we mechanically restrain them, we're going to hurt them through electric shocks, because that's going to prove a point. And I think that there's a real problem with that. I think that there's a lot of times, that's a huge scale. Okay, that's something that a lot of us don't engage in, but at small scale, I think that even the way your body language is towards a child or to a client, man, you could trigger that. You could trigger those physically aggressive and those seclusive practices. Because if you immediately throw somebody into seclusion, every time they do something that you don't like, to give yourself a break, then what are you doing? What are you doing as a practitioner? What are you doing to the clients? And again, going back to what I talked about with the trauma-informed approach and looking at, that child may have been locked in their closet at home, and you're going to throw them into a room and lock them in there and keep them by themselves. Some kids were put in cages, and you're literally going to put them in a scenario that may reissue that trauma response and may cause even more physical aggression. It's been proven in research, even more physical aggression than when you first started. What could have lasted maybe 5 to 10 minutes to change a whole day for a child in a positive manner, to say, what are your values? Maybe use some ACT therapy with kids, some acceptance and commitment therapy like Mark Dixon has put out, and say, okay, now what are your core values? What's most important to you? Is it important to throw that chair, or is it important to promote through the program? Is it important to make your mom proud? What's most important to you? And I think that if we stop as practitioners, we think about these things, that's going to help us down the road to avoid the seclusion practices and the restraint practices that could be damaging to children emotionally. Meanwhile, while they're being used, we just have to be transparent. We have to be transparent. We have to make sure that whatever you do with a child while your supervisor isn't in the room, you would do if your supervisor was in the room. And so no matter who's around you, if their mom or dad were standing right there watching you, would you do it? And that's the question that I think I'm going to leave you guys with is, would you do it? Would you do it? Would you feel comfortable doing it? How would you answer their questions? And how would you ensure their child's safe, not just physically, but emotionally?
Right. And I think that those are some really, really good points to consider. And so with that question, I think that's going to be the end of our debate. We hope that you enjoyed watching, and please feel free to continue this discussion in the comment section. Thank you, everybody. Bye.
Bye.